Our next guest is Dr. Robert A. Smith, who is a cancer epidemiologist and Vice President, Cancer Screening at the National Office of the American Cancer Society. His research interests are cancer epidemiology, evaluation of cancer prevention and early detection programs, and cancer rehabilitation and survivorship. He previously held positions with the Boston University School of Public Health and the Centers for Disease Control. At the ACS, he leads the development of cancer screening guidelines and special research and policy projects focused on cancer prevention and control. He is a founding member of the National Lung Cancer Roundtable, another very collaborative initiative. So, Dr. Smith, if you don't come on up.
Thanks, Dusty. You know, I was told not to bring slides. Anyway, so it's a pleasure to be with you here today, and it's a pleasure especially to hear the stories and to see the courage of survivors and caregivers who are so essentially important to the new directions that we're taking with disease. You know, as long as I've been working in this field, mostly we've been fighting a losing battle against lung cancer. We have only really had prevention. And as a cancer epidemiologist for many years, I was among most of my colleagues who believed that lung cancer screening was a textbook example of a cancer that you could screen for and it wouldn't make one bit of a difference. And when I finally got into digging into the data very deeply, I realized that the studies that we had been relying on for this confidence were deeply, deeply flawed. And about the time I learned this, coincidentally, and it was just at the end of the last century, which I think is so much fun to say, actually, because you only used to hear that in history class or things that were so remote. But we can say, in the last century, we got early findings that showed that CT, low-dose CT, held enormous promise for early detection. And in fact, there were lots of other technologies that were showing enormous progress in early detection. The American Cancer Society and several other organizations convened an expert workshop in Italy to hear all of these out. And it really was a who's who of attendance. And the consensus statement, known as the Verace statement, said that we have imperfect evidence to establish our current policy on lung cancer screening. And it was imperative that national health systems supported prospective randomized controlled trials on the many new technologies that held promise to detect lung cancer early in its natural history and offer the potential for cure. Essentially, a complete cancer control set of options, not just prevention, not just preventing children from smoking and helping adults to quit, but for people who have quit or can't quit, the opportunity to detect lung cancer early in its natural history when prognosis is going to be much better. We have results from the National Lung Screening Trial. We now have results from the Nelson. We know that early detection works. We have amazing new advances in therapy that offer hope to adults diagnosed with advanced stage disease. And yet, at this very moment, with all of this promise, we face a perfect storm of barriers to implement all the new knowledge that we have. So, the challenge in this country, which does not have an organized healthcare system, does not have any way to organize new directions in the delivery of healthcare and overcome the many barriers that endure for, and we've observed them enduring for all the other cancers that we try to address, is that we have a hard time getting people together and trying a hard time getting people on the same page. And many of the organizations in this room do work very well together. But one of the things that the American Cancer Society has done really well, I mean, we've done lots of things well, but one of the things I'm particularly proud of is the creation of these roundtables, which in effect pull organizations together to address common challenges. We do not duplicate what they're doing. We simply become the forum and the glue to get them all at the table, and most importantly, to take on challenges they all would agree are important, but none would agree it's their problem to solve. So the National Lung Cancer Roundtable is 2 years old. We have over 90 organizations, and they literally are a growing who's who of everybody who should be at the table: professional societies, government agencies, advocacy groups, health plans, and it's growing and growing. We have 10 task groups that are focused on particular challenges. In particular, the enormous challenge of activating primary care to identify their patients who are at risk for lung cancer, to deliver an efficient shared decision-making, and to know where they can be referred for screening. There are the access issues, which we've lived with in every kind of healthcare: geography, race, income, education, and lack of health insurance. We have a number of vexing problems, but I think that we have, the roundtable and its opportunities hold enormous potential, and in particular, we are setting our sights, along with many of the other organizations, at finding a way to overcome stigma, which pervades every lung cancer challenge we have. So there's the buzzer. So I just want to say how happy we are to be here. I want to say that these lung cancers go on and on forever. Not lung cancer, these roundtables go on forever. Our colorectal cancer roundtable is in its 20th year. It takes on new challenges all the time, and many of the people in this room are already actively working with us, and I think it has enormous promise. So thank you very much.